because whereas, for example, with hepatitis C, almost everyone who was diagnosed with cancer that had hepatitis C had cirrhosis. They had advanced liver fibrosis or cirrhosis. So that made it, in quotes, somewhat easier. If you still saw someone with hepatitis C, you asked, oh, do they have cirrhosis? If they have cirrhosis, then they should be under surveillance for cancer. On the other hand, a good proportion of people that we diagnose with liver cancer today, we find that, yeah, they have a little bit of fat, a little bit of inflammation in their liver. They don't have cirrhosis, but the strong suspicion is that it's that little bit of fat and cirrhosis in the context of their particular genetic makeup that has resulted in them getting liver cancer. So that's actually one of the biggest problems we face today. In a sense, screening for liver cancer has become more difficult, not less difficult. And one of the reasons we are doing the genetic testing that we are doing, and the tests that we are doing to try to find gene variants that are associated with risk of cancer, is the idea that potentially we actually do a genetic test to see which of the people who don't have cirrhosis but have evidence of fat injuring the liver, which of those people are at highest risk of developing liver cancer. Because there may be people that we can also say, based on your genes, your likelihood of getting liver cancer is really low. You really don't need to worry about being under surveillance as well. So that's, I think, a key component as well. And I just reiterate, I think I'm ready to stop here, just reiterate the point that Lionel made in his talk. Prevention is so much better than cure. And so in terms of controlling the end stage, which is liver cancer, or even if we think about this being end stage liver disease, if we can prevent the causes, and so much better off. So preventing doing the things so that we can improve lifestyle, so we can prevent metabolic dysfunction is so much better than a cure. Identifying those people who are at risk is key to then beginning to allow and being able to put them in programs to detect their cancers early. And we know that in the places where we can do this, we can detect cancers early, we can treat them so much more effectively than if we are not doing this. Otherwise, we find people who come in with advanced liver cancer much more challenging to treat, much more expensive to treat. So I think I'll stop there, and thanks very much for your attention. We'll take a few questions. Just an advertisement for the Africa Cancer Consortium. This was our first meeting in Cairo 2 years ago. We just had our third meeting, which was in Mombasa in Kenya. We had about 260 people. A lot of interest. Of course, it's fairly high burden of liver disease in Africa and viral hepatitis. And so it's been very good to develop that community and begin to train young scientists and investigators.
Thanks, Dr. Oliver, for a great talk. Thanks for keeping the terminology straight, because that's something that I'm still struggling with, so that was very helpful. One question I have is related to risk-reducing strategies for these patients. One question I get often is the role of medications like Ozempic or GLP-1 receptor agonists that are being used for diabetes and weight loss as a risk-reducing strategy for liver cancer. What is the data? Would you recommend that, or can you please comment on that?
Yeah. Thanks, great question. And I sort of enveloped all of that into just saying the drug treatment for weight and for obesity. But the data increasingly suggests that those medications, the GLP-1 agonists, are actually quite effective in when they reduce weight, and because weight is a big part of that metabolic dysfunction, they also improve the metabolic dysfunction. And so they actually likely, and I think there's early studies that suggest that they also will reduce fibrosis, for example. But again, it takes a long time to do those studies and prove a reduction in fibrosis. But I think that's what the early studies and suggest. So just the same way that we showed, it's been shown that surgery to reduce weight gain also can reduce fibrosis. I think we'll find that that's the case. Again, the challenge is as we all are aware, is the cost issue. These are really expensive medications, and there's an equity, the whole equity thing is rolled up in that as well. And again, prevention is so much better than the cure.
Yeah.
So I think it's really important that we are doing things from a public health perspective that reduce the obesity, alcoholic liver disease, and so on upfront as well.
Thanks, Dr. Roberts. Excellent presentation. Well, you did mention earlier about the detection of fibrosis through the blood tests. You did mention the AST/ALT together with platelets. So, do you mind if you comment on the platelets? Are we looking at the lower level count or the higher in terms of fitting into the parameter to determine who's at risk for the fibrosis? Thank you, Louis.
Yes, so as you hinted, generally when people get liver disease that's associated with scar tissue in the liver, they get portal hypertension. And so what happens is that the blood that's being collected from the intestines that's coming through the spleen going back to the liver is facing the stiffness in the liver, so the pressure increases. When the pressure increases, it pushes back on the blood coming from the spleen, particularly the spleen enlarges. And one of the jobs of the spleen is to remove old platelets from the circulation. When the spleen gets big, it starts taking out young platelets as well. So the platelet counts tend to drop. So really the FIB4 accounts, part of what it's looking for is for people who have maybe even subtle decreases in their platelet count that you might not think are important. But those, along with increases in the AST that, again, you might not think are important, but when you add them into the calculation, it triggers the idea that this person might be developing liver disease.
Thank you for bringing the mic. I'm Jibril. I would like to ask you one question on the area of primary care intervention for these conditions. Are you working with public health colleagues to increase access of people at the primary care or at population health? Because prevention is the key here to reduce the risk factors, and those populations are at risk. Thank you.
Thank you. Yes, I think it's necessary. This is really, as primary care physicians, I think it's really important to think about this at a community level. And I think at least it's an interesting thing. Public health people are thinking maybe at the whole population level, and then in primary care, often we're thinking about the community that we work with, the community that are in our panel in primary care. So I don't remember if Lionel hinted at it. We talked about viral hepatitis, for example, as something that's a risk factor for liver disease. One of the things that we did in our primary care panel a number of years ago was we identified everyone who was in the primary care panel in community medicine and general internal medicine at Mayo Clinic who had been born in a country that had intermediate or high prevalence of viral hepatitis B. It was interesting. A fair number of people from Eastern Europe, from Asia, from Africa that were born in a country that had intermediate or high levels of hepatitis B. And in the about 300,000 people in the panel, they found 16,000 people that met these criteria, and that we did not have evidence that they had been tested for hepatitis B. So we actually did a study where if any of the people that we had in our group was going to come back to see their primary care physician. The week before, we would send the primary care physician a note and say, you're going to be seeing this patient next week. At best we can tell they're from a high prevalence, or they were born in a high prevalence, or have lived in a high prevalence country, but we don't see evidence that they've been tested for hepatitis B. So could you have a conversation with them about testing for hepatitis B? And interestingly, over a 6-month period, so we studied 6 months before we started this intervention to 6 months after the intervention. Over the 6-month period that we did the intervention, the number of people that were tested for hepatitis B increased by 4 times. And so I think what it created was this idea that we can actually influence the decisions that patients and their physicians make if we just increase awareness. And I think when we think about metabolic dysfunction associated liver disease, that's something for us to think about also in terms of the primary care setting, the population-based setting. Because people like at the CDC, they're thinking about, how at a population level can we reduce obesity. They're thinking about what the changes they can make to school meals, to access to sugar in drinks that children have, that sort of things. I think Dr. Ibrahim will probably tell us about. But on the other hand, within our community engagement, we can be talking to the communities that we are engaged with about, watching our weight, increasing exercise, making sure that we are doing the things that reduce the metabolic dysfunction.
Okay, my name is Leila. I'm new to this place. I just recently came from Kenya, and I want to ask a question about my community where I came from. Hepatitis B, it's more common, and when diagnosed at early stage and someone is treated, it still reoccurs. And more worse, it spread to the family since it's contagious. So my question is, if the patients are diagnosed at early stage and treated, if it comes back, in which it also goes spread to the people who live around that person. So my question is it related to the lifestyles of GMO foods or a certain type of food where my people usually eat? We like carbohydrates a lot. Our food is never balanced. I have to be frank, you see? So is it related to this wheat we eat more of it? Or, for example, in the Western world where I came now, I see GMO foods are more common and fatty foods, especially the children. The mothers, they usually pack foods more of GMO things, or the fatty foods. So back at home or here where we live in our society, we like sharing a lot. Someone can have the disease at early stage, yet they don't know the signs and the symptoms, or maybe they have not taken their vaccines at early stage. So how can we cope with such a people? How can we treat them? How can we tell them in advance what they are supposed to do? And in my conclusion, is it treatable? Hepatitis B, C, and D.
Wonderful, great questions. And I'll try, I think the key answers, I'll start with hepatitis B. So hepatitis B is treatable. For hepatitis B, we have a challenge. The challenge is because the virus has many different genotypes. And of course, if you go around the world, people have very many genotypes. So people are very variable, the virus is very variable. And what we recognize is that the interaction between hepatitis B and hosts is very different depending on the host's genotype as well as the virus genotype. So I think that's one important thing, particularly for us in Africa, because a lot of the research that's been done on hepatitis B and that was used to develop guidelines for treatment of hepatitis B was done in Asia. In Asia, they have genotypes that are called genotypes B and C predominantly. When genotypes B and C affect Asians, they tend to have much higher loads of the virus than we'll see in some of the other communities. And over time, they tend to get more and more virus expression. So you actually have very high levels sometimes as people grow older and older. And many of them will maintain what we call E antigen positivity, which is that the high level of replication of the virus. So the consequence is that, and the data showed that if the people are above a certain threshold of the virus, you should treat them. And so many people in Asia who are above those thresholds are under treatment. And at this time, the treatment for hepatitis B should be continuous or lifelong. It's been shown that for specific groups of people, if they have like the surface antigen level, if it drops really low, if you stop treatment after about 4 years, some of them will reach a state we call functional cure, where the immune system is able to keep it suppressed. But it's a minority, maybe 20%. So right now, for most people who start hepatitis B treatment, they have to be thinking, I'm going to be on treatment for a long time. There's a lot of work being done now that we, in a sense, have been able to deal with hepatitis C. A lot of the scientists who were working on hepatitis C are now working on hepatitis B. 5 or 10 years from now, we may be able to achieve functional cure for most people and they can stop treatment. But for now, when someone starts on treatment, they should plan to continue. If they stop, then the virus comes back, like you were saying, and they're still at risk for cancer. The other problem is this: in Africa, we have mostly genotypes E and A1. Genotypes E and A1, when Africans have them, tend to be associated with very low levels of replication. So most people who have genotypes E and A1 in Africa don't meet the criteria for treatment that were established based on people in Asia. So a lot of the time, people in Africa will go to their doctor and they'll ask, they'll tell you have hepatitis B, and they'll say, do I need treatment? And they'll say no. But then they'll see that their cousin gets liver cancer and they think, well, my cousin didn't meet criteria for treatment, how come they have cancer? So we've had now 2 rounds of guidelines development by the WHO for hepatitis B. The latest round of guidelines were just published in March. There was very strong advocacy for reaching the recognition that hepatitis B is different in different parts of the world. So it's really important that the decision for who should be treated should be based on where you are in the world. And even in Africa, Africa is a big place. There are places in Africa that you can have hepatitis B that your risk of cancer is low. Maybe you have no aflatoxin exposure. Whereas the other places where maybe they have high aflatoxin exposure, their risk for liver cancer is high. So it's really important that that is recognized. And of course, in Africa, they have the additional problem that few people in Africa can pay for hepatitis B DNA. So they don't even know what the HBV DNA is. And so what the group decided was that if you have hepatitis B, your surface antigen is positive, that's usually an inexpensive test, and you have diabetes, or you are on an immunosuppressant, or you have a family history of liver cancer, or liver disease, or cirrhosis, then you should be treated. So the goal has been to expand the indications for treatment so that we can treat and reduce the risk for at least those people that we know they are at higher risk of potentially getting problems with their liver. The challenging area. GMOs, I don't think we have any evidence that GMOs necessarily are associated with increased risk of liver disease, beyond the fact that, well, everybody has to pay attention to the lifestyle factors. And whether you're eating non-GMO or GMO carbohydrates, there's still carbohydrates, and those are major risk factors. How's that? We can talk some more later.
So So we will pause there with questions. Thank you, Dr. Roberts, for this wonderful presentation and conversation. I would like to turn it over to Jessica, who will share information about a fellowship that she's doing as a medical student that's allowed her to do so in this community.
Hi everyone, and then after this we'll have lunch. So we'll have a lunch break for everybody. We have food from Afro Deli, and if you submitted any dietary requests, we were able to accommodate all of those. I wanted to share about the National Medical Fellowships because I know we have students in the audience today, and we also potentially have people from the community who work with nonprofits who will also qualify. Gotta get this one for the TV. Okay. And we also have some community partners here who might be on the other side of that relationship between the student and community partner to be partnering through this fellowship to fund opportunities to get involved and do some community-based projects. So I'm going to pull up the website for National Medical Fellowships, but I was generously awarded one of the fellowships that renewed for 3 years, providing $10,000 a year towards ensuring my education, and then also providing $3,000 per year for the host organization in the community that hosts you, as well as giving the primary mentor $1,000 each year. So it is definitely a great program, and if anyone in the audience is a nursing student, physician, assistant student, or a medical student, you would qualify for any of their scholarships. And I think it's a wonderful opportunity to have cycles of scholarships, so you can kind of see which ones you're eligible for and apply for all like the hundreds of them, and then hopefully get 1 or 2 or 10 and work with your community organization. And it's a great long-term relationship, and you can really do work closely in the communities that you're interested in. So I'm going to pull up the website while we have some time here because we're bringing in lunch. And if anyone has any questions about it, I'm happy to answer, but I just wanted to plug that because I think that this is a very important setting that we're in right now, where if you just remember that there's this fellowship, if you find yourself working in a nonprofit someday and you think, there's something here that if we had a student who might be interested in interning, it'd be a great way for the organization to get funding and support, and also for you to be a mentor for a student who is interested in participating. So I'm going to get that pulled up, and then did you see we fixed the cropping issue? And then if you go on to scholarships and programs, so I'm on the internet right now, so the ratio is off, so some of it you'll just cut off. It'll be okay if you look up National Medical Fellowships. But really, I just want to highlight that there is a lot of scholarships here. So if you're here and you just know a student or anyone that you think might apply, I think it would be wonderful if you could pass that along. But this website has everything that you would need for helping your students apply and to learn more. And then they give you the eligibility list here.